I am Kumari and I live in a remote desert village named Suduri in district Umarkot, Sindh, Pakistan. I am a housewife with 3 children. My husband Mithun is a driver. Our income is so limited that most of the time we sleep empty stomach. My life was only limited to my family and household chores, cooking, fetching water for home, etc. And in case I get any time, I spend it with gossiping with neighborhood women. One day, few NGO workers came into our village. They introduced themselves as the NGO worker named Hands and explained their purpose of visit. Later they visited again and initiated the formal process of formation of men and women organization. They also asked them to nominate few women to interview to work as health worker and few dais. Finally, I was selected by the committee for this position along with Dai Kari. Later, Hands workers trained me for the training of community health workers and Dai Kari in exclusive trained traditional birth attendance training. I cannot explain my feelings when I became a Marvi worker. After getting this training, I feel that Dai Kari and I can bring a lot of changes in women's lives of our village. I started my work as per my assigned job to register married childbearing age women, pregnant women, and children under 3 years of age of my village with the assistance of Dai Kari. Hands lady health visitors started visiting me regularly and assisting me to verify the cases for contraceptive high-risk women and malnourished children. One day, a relative of the landlord came to our house and asked my husband to stop me, as he doesn't like at all the services I have given and the selling of contraceptives and medicines. I was shocked and scared to continue my work. On a dark night of winter, someone knocked at my door. I was surprised to find that the landlord was standing at my door with his 1-year-old son in his lap. He showed me the child. The baby had high fever, so much so that the child was having fits. I had given cold sponging, 2 teaspoons of syrup paracetamol immediately. After half an hour, the condition of the child improved. I rechecked the fever and asked the father that it was now safe to take the child to a clinic, which I was told is declared as mother-child friendly by Hands staff. The next day, the landlord came again to our house. He called me and my husband and told us that the doctor of the clinic had informed him that the timely first aid to the child in the village had saved his life. He had tears in his eyes and he said, "From today, you will hold a place of pride in this village." Pakistan, with the population of 177 million, is at the verge of population explosion. After 63 years of independence, 64 million Pakistanis do not have access to health facilities. 276 women die out of 10,000 while giving birth. Only 41% of women are attended by a skilled birth attendant. 75 children out of 1,000 live births die before their first birthday. Although 95% Pakistani women have knowledge of at least one modern contraceptive, but the contraceptive prevalence rate is only 29%. Considering the low literacy among women folks, the LHW's program could cover only 54% of the population, thus leave huge 46% highly marginalized population vulnerable for ill health and hence deaths. District Umarkot is the poorest district of the country, located in southern region of Sindh province of Pakistan. It consists of barren tracts of sand dunes covered with thorny bushes. The population of the district is 860,000. 49% population is non-Muslim, that is Hindu, and most of them, 74%, are low caste. Almost 74% of them are living under the poverty line, with literacy rate of only 6%, whereas 53.6% of the total population is deprived of lady health worker services in district Umarkot. The Marginalized Areas Reproductive Health and Family Planning Viable Initiative, Marvi, aims to pilot a modern project for integrated project of community development. Word Marvi considered as dignity and women empowerment, is adopted from the name of women in folk stories. The project linked livelihood with reproductive health and family planning services in LHW's uncovered areas. Health and Nutrition Development Society, HANDS, implemented this project with the assistance of Thardeep Rural Development Program, TRDP, and collaboration of District Health and Population Welfare Department. The financial assistance to the project is given by the David and Lucille Packard Foundation. HANDS is a registered, tax-exempted, and PCP certified, European Union accredited, not-for-profit organization working since 1979. We work in key programs of health, education, poverty alleviation. HANDS is benefiting more than 13 million population of 16,703 villages in 24 districts of Pakistan. The first phase of Marvi project initiated from 1st November 2007 with baseline survey and has concluded on October 2010. The baseline study was conducted before the start of intervention. The social mobilization strategy was initiated with the formation of 700 health committees or community groups. 1,128 members of these groups trained. One Marvi worker and a DAI were selected per 700 to 1,000 populations per village, and hence 350 villages were identified. The total population benefited from the project is 400,000 directly, and the whole district population of 858,000 indirectly. Marvi workers and traditional birth attendants (TBAs) were trained through 12 training events, which is overall 60 days for each provider. The project has trained 350 Marvi workers and 350 TBAs and has supplied with health products, which include basic medicine, ORS, safe delivery kits, sanitary pads, condoms and contraceptive pills, and iodized salt on subsidized cost. Project also supported to Marvi workers with stipend of Rs 1,200 per month and nearly 30% subsidy for each supply. Each Marvi worker has asked to establish a Marvi house in one of the corner of their house. They are also supported by a record-keeping system. After 3 years of intervention, the end-line evaluation stated that the mean age of Marvi worker was 30 years. The end-line evaluation depicting that the majority of 63% of the Marvi workers had attended at least primary school. Printed material, posters and flip chart sets were displayed by 93.3% Marvi workers. It was almost same in MTR. The knowledge of Marvi workers about the 3 delays was found 90%. A referral strategy has developed by Marvi workers for their respective villages. The strategy was comprised of identification of women with danger signs during antenatal, natal and postnatal period, identification of the readily available vehicle with the contact number of the driver. The volunteer blood donor have been identified in all 350 villages and their lists were developed. The village-based telecommunication, that is wireless phone, cell phone and transport source were available and identified in all villages. Their name and contact numbers were displayed in 74% of Marvi houses in end-line findings. Marvi has referred nearly 54,255 women, 8,594 children with complication to secondary care facilities and saved their lives. TBAs conducted 6,951 normal deliveries by using 53% safe delivery kits, while it was used 47% in MTR. And evaluation verifies that 83% of Marvi workers know the recommended number of antenatal checkups, that is at least 4 antenatal during the pregnancy. 100% Marvi workers reported and more than 2 postnatal checkups necessary during the postpartum period. 51% of the Marvi workers had knowledge of at least 4 danger signs of antenatal, natal and postnatal period, while 41.1% of the TBAs have been able to identify at least 4 danger signs during antenatal, natal and postnatal period. HANDS designed its behavioral change communication strategy on the basis of smart chart communication technique. 17 sets of posters, flip charts and other material was provided to MWs as health educational material. Marvi is conducting health awareness session with the assistance of TBA by using this material. Up till now, they have conducted 41,316 health awareness sessions and 42,000 women support group meetings during Phase 1 and reached to 659,196 participants. As part of advocacy strategy, Marvi project organized many mass mobilization events like Marvi Health and Culture Mela, Women Festival, Children Mela, etc. The end evaluation results revealed that 93% women knew about Marvi and 65% women knew about availability of family planning method with Marvi Worker. In end evaluation, 96% women knew about at least one modern method of contraception. In the end evaluation, current user of family planning were 22% in comparison of 9.3% in baseline. It reflects that there is an increase of 12.7% in current user of family planning. From the baseline, 56.2% women identified Marvi House as a source of family planning method in comparison of 41% in MTR. 37% of the married women sought antenatal care in their last pregnancy in an evaluation, as compared to 31% in MTR. According to Endline evaluation, 93% of women knows Marvi House is present within their village. 62% women mentioned TBAs as their healthcare provider within their village. 82% women identified Marvi Worker as healthcare worker within their village. Hence, social marketing department ensured the smooth supply of health product throughout. Marvi workers were able to sell the health products of amount 2.3 million and earned average rupees 1700 per month. And evaluation results showed that 55% TBAs had knowledge of 3 cleans of delivery, that is, cleaning of hands, clean place of delivery, use of safe delivery kit, while it was 31% in baseline. And evaluation result also observed that 70% TBAs have knowledge about 3 delays against 73% TBAs in baseline. Marvi project also supported 50 public sector health facilities through supplies, equipment, technical training and development into women-friendly health facilities. Hence, monitoring evaluation strategy starts from community-based record of MWs, reported through health promoters and then district to office web-based database which is linked to the head office. There are regular supervisory orientation visits by hand senior and mid-level management teams. Monthly progress reviews, midterm reviews and annual reviews were conducted to maintain quality. District government officials from Health and Population Department also supported in supervision. Marvi pilot project model has proved when there is no lady health worker, a low or no literate girl if trained as community health worker along with trained TBA can deliver RH and FP service with the support of community-based group. The success of Marvi intervention already took her out of the boundary of district Umarkot. Millions of Pakistani women and children are waiting for her. Let's help us to scale Marvi intervention throughout Pakistan.